Now we have Dr. Ramamurthy sir with us, who's going to implant a toric IOL. So is it in focus?
Yeah, we can see the slide of the patient right now.
Yes, so
Soham is going to tell us about.
65-year-old gentleman, already one eye pseudophakic, will be operating the left eye. It's a NS 2 to 3 grade cataract. The posterior pole examination is normal. Specular count is good, 2700. And the IOL choice here is a VVT toric with 22 diopters. And the implantation would be at 16 degrees. The corneal astigmatism of 1.01 diopter.
Very good morning, everyone. Can you hear me?
Yes, we can hear you, sir.
Morning, Professor Jagatram, Dr. Somshila, and the rest of the panel and delegates. I am going to be operating, as was mentioned, on a 65-year-old with a diopter of against the rule astigmatism. The plan is to put a VVT toric, a T3 model. Basically, I believe that there is a surgically induced astigmatism is just about 0.1. So because of that, the toric calculator shows that the patient requires a T3. I'm going to be using the Centurion, which and it's the Rivalio microscope, the Luxa Rivalio. So excellent setup, beautiful settings in Trenetralaya. And these are my, with the Varion overlay, I'm going to start the surgery. Side ports is what I make first. The surgery is being done at a topical. These are 1 millimeter side port incisions that I make at 70 degrees apart. And the Varion overlay allows me to exactly position the incisions where I want them. And this is a little bit of xylocaine going into the eye. The dilatation is extremely good in this case. But it's always a good idea to inject some intracameral anesthetic, because I believe that sort of gives some uveal anesthesia and greater comfort to the patient. Main port. I make a 2.4 millimeter main port incision now, because earlier it was all 2.2 millimeters, but now I believe a 2.4 millimeter helps me to introduce the phaco tip as well as the instruments, the cartridges very comfortably. And it's been well proven that irrespective of whether it's 2.2 or a 2.4, you get the same amount of centroid value of the surgically induced astigmatism. And now a simple HPMC is what goes in. It was being asked earlier. I use HPMC right through my surgery except during quadrant evacuation when I have a coat of viscoat onto the endothelium. And I'll be referring to that later on. I have the capsulorhexis marker with the Varion, which is on display. It's at 5.8 millimeters, as you can see. I aim at only a 5.5 millimeter rhexis, but what I'll be doing is to run the rhexis along within the margins, some saline please, within the margins of the Varion overlay. So that tells me that I'll have about a 5.5 millimeter rhexis, well-rounded rhexis, and it is centered on the visual axis. With any of these modern IOLs, rhexis I believe is the most important aspect, because you want a good coverage of the entire 6 millimeter optical lens. Adequate coverage. At the same time, you do not want too small a rhexis. So time spent on doing a rhexis well is always time well invested.
So we have a second mic on from the OR, I think. Can we please turn that off?
Sorry?
There's second mic on in the OR. I think probably Sonu's mic is still on.
I didn't get the question. What is it? My mic is not on?
No, you're doing fine, sir. There was another mic, somebody else's mic, which is also on. Okay. So, yeah, but you're doing fine. We are able to see and...
I got the rhexis.
Yeah, excellent continuous curvilinear capsulorhexis. And Dr. Ramamurthy has completed it with the needle cystitome. You always use needle cystitome or sometime you use Utrada forceps?
I always use needle cystitome. The only time is if there is a tendency for the rhexis to run off to the periphery, then I use a micro rhexis forceps, go through the side port, get hold of it, and then use a brand little maneuver to get the rhexis back. सीधा देखिए, light पे देखिए, very good. जरा सा ऊपर. I did a good hydrodissection, and you could see it. And I always believe in rotating the nucleus quite adequately. This breaks up whatever corticocapsular adhesions that are there, and also makes the rest of the process of phacoemulsification much easier. And now I'm going to be using the Centurion vision system with the active Sentry overlay. I'm using an intraocular pressure of just 30, which should translate to a bottle height of 41. And basically, सीधा देखिए, light पे देखिए. As you can see here, I introduce the instrument with it turning downwards. Then I go in, remove all the cortex and the nucleus, and remove all the cortex and the epinuclear material that is there. And this system gives an excellent control as far as the fluidics is concerned. I usually use about 550 vacuum and just an IOP of 30, about 34 to 36 as the can I have a sculpt? I create always a small strange chop. ये आपने तो मुझे चॉपर दीजिए, chopper. I would have exposed my tip a little more. So chop mode. You can see the first chop that has occurred. Can we have less noise, please?
Yeah, definitely very nice phaco chop. And these multiple chop help for better removal of these fragments.
And it's important that you make sure that it propagates through and through. The Rivalio microscope with its oblique illumination as well as the axial illumination gives an excellent visualization. And I think the number of chops I make is directly proportional to the hardness of the nucleus. Since this is just about grade 2 to grade 3, I think I'm quite happy with making it to 4 chops. I just make sure they're distinctly divided, because then evacuation of these fragments becomes extremely easy. And till now I've been using only HPMC, and now is the time I will use viscoat. See the light pe dekhiye, because I think that gives excellent protection for the endothelium. As you can see, all my maneuvers till now was happening in the within the capsular bag, but now is the time when I'm going to be bringing out visco. Now visco. Now is the time I'm going to bring the nucleus fragments outside, and I do not want visco in the center because that is thermogenic, and this is perhaps the only situation with modern machines you get a wound burn. So I actually want to operate in a lake of viscoelastic, normal HPMC, but use the visco to coat my endothelium. Of course, for this cataract, quadrant removal. For this cataract, this may not be so important because it's not a very hard cataract, but whenever dealing with a hard cataract, I find it helps me very much to get a clearer corneal endothelium on the post-operative day 1. So I keep the plane of phacoemulsification as posteriorly as possible. And you can see the excellent control that I have with this machine. It's also because of the active sentry which automatically adjusts for the bottle height, make sure that the leakage compensation is there, and then gives an extra impulse as far as protecting the maintaining the intraocular pressure at 30 is concerned. There is some fogging of the lens. Can you please clean it? My left lens, just 1 minute. You can just get a piece of lens. This lens ko jara. IA. I always favor a bimanual IA. Yeah, just clean it, please. Thank you.
So the eye is not centered at this point. It is centered.
Okay. Is it better?
Yes, it's fine, sir. I think you have some. We can see that there is a little bit of nuclear fragment, perhaps, or epinephrine at the wound.
Haji? Now, No, it's okay. It's quite okay. Thank you. Cortex aspiration. As you can see, right through all my steps, I keep the IOP at 30. And you can see I favor a bimanual IA always, because I think that gives me excellent access to almost all sections of the capsular bag. And that was a small bit of nucleus which I am just taking out. And you can see my aspiration cannula is sandblasted, and with that I am able to, whenever there is some amount of recalcitrant fibrotic patch, I am going to polish that off with that. And with the Centurion vision system, with the you have always had the advantage of the active fluidics and the balanced tip and advanced integration. And as you can see here, they have used an Argos machine for calculating the intraocular pressure, intraocular power, and then it's integrated with the Rivalio microscope, the Centurion vision system. So it's an integrated workflow that you have here with one machine talking to other. The Varion also has another dimension, and especially when you're using a toric intraocular lens, the positioning of the lens becomes so much controlled, because there is already a cyclotorsion compensation that's integrated into this. And I always feed in a SIA value of 0.1 in my Barrett toric calculator, because it's been well shown that with the centroid value of the toricity being important, it's not 0.4 or 0.5, but most of us are in the range of about 0.1. And with this, our results are much better. And I find that my usage of torics, whether it's monofocal, BVT, toric or trifocal torics, is all in the range of about 45 to 50% now. And there's a little bit of polishing of the rim of the anterior capsule that I'm doing, so it's not so important. Can I have just an irrigation flow? I will always tend to saline, do a hydro polishing of my capsule, and I believe that whatever little small fragments might be there, that's also taken care of by this. It's more important to have a central clear capsule. There are small cortical fragments, as you can see at 9 o'clock, but that I think will be subsequently taken care of. Now I'll take it out right now. I plan to do a hydro implantation of the intraocular lens, And this lens that I'm going to implant is an extremely interesting lens using the X-wave technology. X essentially stands for extended. So there are two surface transition elements in this lens. One is a small ring elevation of about 2.2 millimeters. Another is a curvature change in the center and lens, intraocular lens. And the external ring, आप लोड करिए, हाँ? नहीं load it. I mean, the external ring actually stretches the wavefront, and the internal curvature shifts it. So the interesting concept is that I'm asking him to, my excellent assistant, to load the lens. I have been spoiled by my sisters, and frankly I must admit that I don't know how to load these lenses properly. I'm more comfortable them doing it. And basically these lenses are no different from the Alcon IQ. So as far as the loading of these lenses is concerned, there is no different. So there's nothing that I'm sure all of you are comfortable with that. And I'm going to be injecting this lens. You can see the toric overlay already there. And I'm going to do a wound hydro implantation of this lens. We'll come to the features of the lens. As you can see, nicely goes in a very controlled manner. And Sinski hook. And you can see it's I was talking about the surface transmission elements on the either side on this lens, and because of which there is a stretching and shifting of the wavefront, and it's an excellent lens for intermediate vision. The patient is very seriously interested in near vision, then it might be somewhat inadequate. You need bilaterally implanted. Many of these patients are able to manage without glasses, but at the same time, if they seriously are interested in near vision, then they may require a 1 to 1.5 diopter of watt power saline. But otherwise, the major advantage being that the quality of vision that these patients have is very similar to what you get with a monofocal intraocular lens. There is no deterioration in the quality of vision at all because there are no diffractive rings, there are no refractive changes. It has an asphericity value of 0.2. With the stable force optics, these toric lenses also remain absolutely stable, spot on, and during the period of follow-up, not just of these lenses, these are more recently introduced, but even with the toric monofocus in the IQ platform, we are all aware that these lenses remain very stable over a period of time. And I do feel that there is a slight mismatch as far as the saline.
Thank you, Dr. D. Ramamurthy, for your excellent demonstration of the live surgery and implanting this VVT toric IOL. It is excellent.
Thank you. Yeah.